Good morning, everyone. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Thank you so much for joining. This is your opportunity to ask questions directly about COVID-19. You can put questions in the chat box below. You can also put a hashtag #AskDrArwady. And today, as you can see, we have a special guest. This is Dr. Richard Novak, and he is one of the main infectious disease experts in the city of Chicago. He is the head of the Division of Infectious Diseases at the University of Illinois at Chicago, and he's worked for almost 4 decades, right? Doing HIV especially work and research, really leads a big team that focuses on HIV clinical care, and then this community clinic network, which you began back in the early 1990s and is now a network of 7 HIV community-based clinical and research sites throughout Chicago. And then importantly, the reason that he's on here is that has a very, very long experience in terms of vaccine and clinical research, and University of Illinois at Chicago is the site of the phase 3 vaccine trial that is furthest along here in Chicago. And I know a lot of you have had lots of questions about vaccines and getting involved, and so really appreciate Dr. Novak coming on and lending some expertise and being able to answer your questions. So today is Tuesday, September 1st. Let's just check our social distancing. Give me your hand there. Again, this is your easy way to make sure you're keeping your distance. We obviously need folks, doing all the things that we know work in terms of wearing the masks, keeping physical distancing, doing the hand washing, avoiding crowds, protecting vulnerable individuals. So with that, you can start putting some questions into the box, but I'm going to start just again welcoming you. And could you just give folks a little bit of a sense of what your work was like prior to COVID and then what you have been working on most recently?
Sure. Well, so as you mentioned, I've been doing HIV work pretty much my whole professional career, and big part of that was working on HIV preventive vaccine development. So for the past 25 years, I've been working in vaccine research, and we were actually about to launch another HIV preventive vaccine trial when COVID-19 hit, and that put that project on hold. But like other sites that do this kind of work, the NIH came to all the existing sites to ask us to participate in COVID-19 related vaccine research, and that's largely because we had already developed the infrastructure to do that kind of work, and so we had the staff, some of the staff, and lab support to do that, and also the experience in how to recruit and retain people in vaccine trials. So all the NIH clinical trials networks for HIV were rapidly incorporated into what's now called the Coronavirus Prevention Network, or COVIPN.
So these are the HIV across the country that were pulled into this. Gotcha.
Right. Other sites such as ours, there are over 30 of them, and so we became the COVIPN, and we started having weekly phone calls and planning, and we're part of what is called Operation Warp Speed, and because of that, all these trials are being done at an accelerated rate, far faster than anything I've ever done, also and much larger than anything we've ever participated in. And so we were selected to participate in the first of 5 vaccine trials that Operation Warp Speed is doing, and that's the Moderna study. The study is intended to enroll 30,000 people. Our goal was to enroll 1,000 here in Chicago. I don't know that we'll meet that goal because the study opened at a number of commercial sites around the country before the NIH sites got up and running, and we just finally opened our trial a week ago today, actually, a week ago yesterday. So we're building up speed and capacity as we go, and we're enrolling briskly now, and so far things are going smoothly for that study. We are continuing to add additional staff. We just received a mobile clinic from the operations center of the COVIPN yesterday, which we'll be using for follow-up visits. So I can give you a little bit more background on what else the Operation Warp Speed is involved in. So they officially announced opening of the AstraZeneca trial today, I believe, and it's going to be done at numerous sites in Chicago. We're not going to be one of those. And then following that, there'll be, just in a couple of weeks, they're going to start opening the Janssen vaccine trial, which is the third COVID-19 vaccine, and we will be participating in that. And there are two others. There's one by a company called Novavax and another by Sanofi. And these will all be open by December. Each one of them enrolling a huge number of people. The Janssen vaccine, I think, is targeting 90,000 people to enroll. It's sort of combining a phase 2 and phase 3 into the same operation. We will probably participate in one of the other studies after we're done with the Janssen vaccine. But so basically, we're just enrolling one, and as soon as we finish the Moderna, we'll immediately roll into the Janssen vaccine enrollment, and then after that, we'll roll into the third vaccine trial that we will be committing to shortly. Additionally, CoVPN is involved in studies with monoclonal antibodies, which is another strategy for preventing and treating COVID-19. And we're involved with the treatment, the prevention part of those studies. So there are two that we already have open. One, which is a Lilly product. It's a monoclonal antibody, which means it's a form of passive immunity. Instead of using a vaccine to induce your body to make antibodies, which is a vaccine strategy, this is just giving you the antibodies as an infusion, and so you get an immediate immune protection from the infusion. It lasts probably for several months, and so we've begun that study in nursing homes, and it's targeting nursing homes that have had demonstrated outbreaks of COVID-19. We're already in 4 nursing homes in Illinois. And then the other study is by a company called Regeneron, and they have a cocktail of monoclonal antibodies which are extremely potent, and they're very potent, and you achieve very high levels of immunity right away with the infusion. And that study is not open yet, but we'll be targeting households that have an index case of COVID-19 within the household, and then we'll be trying to enroll the other members of the household, see if we can protect them from getting infected, because as you know, it's common that other members of the house acquire
especially in Chicago. That's what we're seeing a lot of right now. Yeah.
Multi-generational homes. So I think this is an ideal place to do that work.
Great. Oh, beautiful summary. Lots of things going on. And I think this is where, I'm sure people are going to have questions. We've talked about antibodies broadly. People have certainly, just as a reminder, antibodies are sort of the body's immune response when you've seen a virus. And so where we've talked about antibody testing, that's if somebody was infected with COVID in the past, you can check somebody's blood and see, did they build some immune response already? The other ways that you build that immune response are by giving somebody a vaccine, which lets them build the immune response without ever getting sick, or this way of actually just infusing, meaning sort of putting in through an IV, these antibodies. And it's really interesting to think about, before we have a vaccine, are there ways that we can protect some of these higher risk folks? So are people able, if they're interested in participating, in some of these, I know some of the settings that are nursing homes, those are sort of defined in a given nursing home, but how can people get involved with that?
If you want to be involved in the vaccine trials, you can call our registry. The number is, I just want to verify, it's 312-355-0656. 312-355-0656. I have a call center. A number of people will answer the phone and will take your information, and you'll become part of the registry. If you may be asked to participate in the Moderna study, or if not that one, then as I said, we have others that will be following immediately, so there'll be no shortage of opportunities. For the monoclonal antibody studies, those are really targeting people who are sick. So we're enrolling people from testing centers. We're identifying people who test positive, and then approaching them if they have about whether or not they'd be interested in us coming to their home and enrolling their household members.
Great.
So when that's ready to go in a couple of weeks, we'll be enrolling that way.
Okay, wonderful, thanks. So let's go ahead and do a quick data update. And I know people are already starting to put in questions, so keep doing that. But as always, we do like to take a quick look at what our Chicago data is looking like. So can we bring up the dashboard here? Got it up? Great. So if we look at where we are in Chicago today, first of all, on this overall citywide dashboard, we are at a 5.3% positivity. Again, that's our test positivity. What percentage of tests are positive divided by all the tests that are being done? We want that number back under 5%. I am not happy to see it over 5%. Granted, it's not at the 8% level that we're seeing in some other parts of the state or even worse, but we really want to see that number coming back down. We look at what our daily testing numbers look like, and those have been holding pretty steady. We're now really regularly averaging over 8,000 tests a day here in Chicago, which is almost twice what we were averaging just a couple of months ago. But the concern is that even while testing continues to rise, that percent positivity is not falling. And so you know that there is continued disease really in communities. We do still see excess disease, sort of more than we would be predicted, particularly in Northwest and Southwest Chicago, especially in communities that are predominantly Latinx. And there's been a lot of work ongoing, and thanks to the many partners and folks who have been working in those spaces. We've also been pushing testing additionally, as well as education, outreach, et cetera, all in those directions. If we look at our case numbers overall, you see that here in Chicago, we've passed 70,000, so we're at 71,285 now, confirmed COVID cases in Chicago. As a reminder, those are just people who have tested positive with a diagnostic test for COVID. We estimate probably at least 5 times that number have actually been infected with COVID. We estimate that partly based on what we know about mortality rates in the disease, some other modeling. But regardless, we've passed 70,000 now confirmed cases. And right now we are adding on average 348 cases per day. We would like to get that number here in Chicago back down under 200 as a reminder. And we've said a real concern if we see that number pass 400. 348, you can see, compared to a week ago, is up about 1%. We were at 343 a week ago. We're at 348 now, continuing to just see this slow increase. And although it's been relatively stable over the last week, we've been in the high 340s, low 350s. We really want to see that sort of turn around and come back down, particularly while we're still in good weather here. And we really want to see that percent positivity also turn itself around. I think if we look at some of our daily demographic data here, you can see our deaths remain very stable at 3. Our hospital numbers remain stable. Our people positive, so as opposed to the percentage of tests that are positive, where you discount anybody who's had multiple tests and you just count them once. So the number of tests divided by the people who have been tested is up over 7% still. And that's what we use where we're comparing across geographies or across race ethnicity groups. And that number we would also really like to see coming back down. So I think that's all we'll do on data for today. If you're interested, at 1 o'clock, we will be doing a press conference that talks a little bit about the data, also where we are on travel order updates, et cetera. So just after that. So let's go ahead and turn to some questions. And we are already getting things in, so this is good. So first of all, let me just maybe start out with the basic question here of how do we know these trials are safe, especially if you are talking about doing them more quickly than normal?
That's a good question. So there is safety data already from the phase 1 study in the Moderna particularly, and we have it now for the AstraZeneca as well. But the Moderna study, phase 1 was looking at a dose ranging study. So I looked at a variety of doses to see what was optimal for generating an immune response. Phase 1 is really looking at safety and immunogenicity. So how safe is it, how good an immune response. And they demonstrated that at the dose that we're using in the phase 3 study, it was actually quite safe. That people had minor side effects if they had any. There was a minority of people who got side effects. The side effects are not different than you might get from flu vaccines. Some people get a fever, some might get body aches, most people get nothing. Some people reported headaches. I hasten to add that, you know, if you get those side effects, that's really a sign that your immune system's responding to something, and that's an inflammatory response, and you expect that with the vaccine because that's part of developing an immune response. So there's certainly no severe side effects. Nobody got hospitalized. Nobody had worse. I mean, people had minor side effects, and so far in the study that we're doing here in Chicago, we've seen the same thing. Most people have nothing. Few people have had some minor side effects like fever and body aches.
Yeah, okay. And I know what we've talked about a little bit also is that some of the way things are being sped up are the fact that they've already started production of some of these vaccines,
right,
even while we're doing these phase 3 trials. And we've talked a little bit about how we have to finish the trials, like to know that a vaccine is safe and effective. But one of the ways to speed it up has kind of been on that production side.
Yeah, well, that's true. Another thing I want to say about these vaccines is that these vaccine strategies that are being used for coronavirus were developed earlier for other viruses, actually. They were on the shelf, so to speak. They were, for example, the virus, the Janssen vaccine, we were getting ready to do an HIV trial, vaccine trial, with the same platform, which means that it was the same way of delivering vaccines. So we knew a lot about it already. And the Moderna vaccine was being developed for other viruses as well. So it was, when coronavirus came along, it was relatively simple to just take the virus, the coronavirus, and insert it into these other modalities. So it's not like we just started from scratch making these vaccines. There's quite a bit that was known about them already.
Okay, great. We're getting a few questions in about who is enrolling, who is the target population, and some more specifics. Brittany Ann Cummings on Facebook is wondering, what about pregnant women in the vaccine? So can you talk a little bit about maybe who's enrolling at this point?
Yeah, so our goal is to enroll people who are at risk of getting COVID-19 illness, not just acquiring the virus, because the endpoint for this study is reducing the number of people who get sick. So not so much reducing the number of people who actually get the infection, but people who get the disease. And that's true of a lot of vaccines, actually. I mean, we're also measuring if we prevent them from ever getting the virus, but you have to think about that. I mean, the virus has to get into your body in order to induce an immune response. And similarly, if you already have immunity from a vaccine, you won't know it until the virus gets in there, and the vaccine immunity can work. So, so in order to see those cases, we want to get people in the study that could get sick. So that means generally people are older, over the age of 65, or people who may be younger but have some underlying chronic illness such as diabetes, lung disease, heart disease, obesity is considered a risk factor. And additionally, we want people who work in settings that put them at risk. So people who are first responders, people who work in face-to-face jobs like restaurant workers, people who work in factories or warehouses, who work in large congregate settings, people who live in congregate settings, people who live in multi-generational households are considered at risk. So those are the kinds of people we most want in the study. And lastly, we're very interested in recruiting more minorities, particularly racial ethnic minorities, African Americans and Latinx, because they're disproportionately affected by the disease. And it's critical that, that African Americans and Latinx people participate in the study so that we understand whether it works in those subgroups. And so we're making a big effort to reach out to the African American communities and the Latinx communities, and we're recruiting heavily in those neighborhoods.
Okay, great. Can pregnant women get the vaccine right now?
The answer is no. We don't know about safety in pregnant women, and until we know that the vaccine works, we're not going to expose women who are pregnant. And in fact, women who participate who are of reproductive age need to promise that they will use some form of birth control while they're in the study so that they won't get pregnant. This is an RNA-based vaccine, which means it's genetic material, and we just don't know if it would get into the fetus or not. It's it's safest not to go there until we have more information.
Yeah, and similarly, I'm presuming you're not enrolling children, I would guess. Is that also right?
This study doesn't include children. Yeah. It's for people over the age of 18. There is a separate trial being designed for children.
Yep. And this is where, you know, often in kind of this vaccine development, this is where we've gotten a lot of questions about when will vaccines probably be available for kids, et cetera. And that you really first, and, you know, even, and you please chime in here, but when you first start testing vaccines in those early trials, you're really just doing them in younger, healthier people, looking for side effects, making sure that you're not, you know, you're accidentally inducing serious problems with this. And then as the vaccine trials sort of expand, you enroll different age groups, different vulnerabilities. And so now that these are moving into phase 3, that's when you're starting to talk about these tens of thousands of people. But even within that, there are some populations like children or pregnant women who you want to do more of the testing even before you move to that group. And so that's why, you know, I'm interested in your opinion on this. You know, most likely, I think, as the vaccines eventually become available, they won't be available for kids, most likely right at the beginning. They won't be available for pregnant women. We'll be doing extra sort of studies and safety studies in those populations once we're secure that they're safe in the general population. Do you want to add to that?
That's absolutely right. Oftentimes we accumulate information on pregnant women through a registry
Yep.
system, whereas once a vaccine is licensed and people are getting it, inevitably there will be people, there are women who are pregnant who will become pregnant who have received the vaccine, and we'll collect that information. They'll be asked to provide their information to a national registry, and that way we'll accumulate a fair amount of data on pregnant women, and that's a somewhat more ethical way than giving the vaccine to women who are, and then have them become pregnant, or while they're pregnant, not knowing what the outcome is going to be for their fetus.
Yep. Bridget McCarthy on Facebook is asking, do scientists release any preliminary data on how effective vaccines are in the phase 3 trials?
Well, they don't. So the study is done as a double-blinded, placebo-controlled trial. And that means that I don't know what I'm giving to the participants, and they don't know what they're getting.
Between either the actual vaccine or
the
a
placebo. I mean,
yeah.
Why do we do that? Because we have no effective alternative, so we have to test it against something. It's a controlled trial. In the end, it's our hope that there'll be fewer cases of COVID-19 in the vaccine arm than in the placebo arm. That would be an indication that it works. But we can't unblind the study early. However, as with all large-scale studies like this, there's something called a Data Safety Monitoring Board. That group of scientists who are not blinded to the data, and they look at the data at regular intervals, I think it's monthly, to make sure that what they're seeing is safety, the vaccine is safe, and ultimately they will have the opportunity, when there are enough cases or endpoints in the study, enough people have gotten sick in the study population, they may be able to stop the study if they see that the vaccine is in fact effective. Then it would be unethical to continue, and they would announce stopping of the study and unblinding the participants. Or alternatively, they could say, this vaccine is not working, and it's never going to work even if you finish the study, and we're going to stop it for what we call futility. It's just it's a dead end, and we're just going to end it now.
Yeah, it's the same idea around some of the drug development, right? You sort of follow, and once you've sort of seen that something works or something doesn't work, that kind of can mark the end of the trial. So.
Right.
Faith State on Facebook is wondering, actually you addressed this a little bit, will there be clinical trials with monoclonal antibodies for people who are positive but don't live in nursing homes?
That's what the Regeneron study is for household members of people who are positive. There are treatment trials with the same monoclonal antibodies, by the way, both outpatient and inpatient studies that are being open in various places. We will probably participate in one of those inpatient treatment trials. And it's with the same products, because they do have great potential for treatment as well. But this household study with the Regeneron product is actually a really exciting study because it will catch people who are at risk. We'll be testing people in the household after we identify the index case. So somebody's positive, we'll approach them about going to their home, we'll test everybody in the home, and we'll get the answers fairly quickly if they're positive or negative. They will still get the product whether they're positive or negative, and so we'll get some inkling if the antibody interrupts disease in the people who are positive, and also we'll learn if it's causing prevention in the people who are negative in the household. So it's also a placebo, double-blinded placebo-controlled trial, so that's how we'll find out if it's actually doing something or not. But one of the beauties of this study is that we could get the answer really very quickly, within the next 2 or 3 months, before we have a result of a vaccine.
Yep.
We may learn that this is an effective prevention strategy that will be available fairly early on. So it's a very important study and very exciting.
Great. We are getting a number of questions here about flu shots, which is a different type of vaccine. So let's maybe pull a few of these together. So I'm just going to read a few of them, and then maybe we'll hit them all together. So Nancy V on Facebook is asking, aren't flu shots only good for 3 months? Jean Brooks on Facebook is asking, I got my flu shot 2 weeks ago. I'm reading maybe this is too early. Do I need a booster? Joanne Dovidoskis Doria on Facebook is saying, should seniors get flu shots earlier, like now? And Brittany Ann Cummings again, actually on Facebook, is saying, when should people get the flu shot, pregnant and young children? So I'm going to hit all those and then feel free to chime in. So the bottom line on flu shots is that virtually everybody over the age of 6 months, with just a very few exceptions, should get the flu shot and should get the flu shot every year. It's actually especially important for pregnant women and for children over the age of 6 months. And in fact, if you are pregnant, talk to your OBGYN or to your family practice doctor, whoever is doing your prenatal care, and they will share with you that it's, making sure that you are protected against the flu also helps protect your unborn baby. And that has to do with part of why we wait that 6 months for the young children, because they get their immunity from the mom's vaccination. And every single year we make a new flu vaccine, and that is because influenza, the virus, which is a different virus than the COVID virus, it has quite a lot of mutation every year. And so in that context, we sort of see what strains were circulating in the southern hemisphere, which has the opposite northern and southern winter summer, and then make a new strain every single year. So you do need to get a vaccine, a flu vaccine, every year. But as soon as it becomes available, and it sounds like Jean Brooks here was right up at the beginning there, just because it's just started to move into Chicago in these last few weeks. As long as you have gotten it sort of starting in August on, you have gotten your flu shot for the year, based on everything we know now about this flu shot. If we were to see additional strains, occasionally there will be boosters, et cetera. At this point, we want everybody, and particularly seniors and people who are at higher risk for flu and for COVID, to start getting their flu vaccine and get it now. It's not like you need to wait till December or January. In fact, getting it now gives your body the couple of weeks it can take to sort of build up some of that immunity. And we really want people protected against flu, because that helps, number one, if you're less likely to get flu, you're less likely to need the healthcare resources, the testing resources that would also be linked to COVID. And we worry about the surge. Every year we see a big surge of people getting really sick, hospitalized, and even dying from influenza. And if I think about that surge on top of a potential COVID surge this winter, we could really be in a bad shape. So I hope we got all of those in there. Seniors should get flu shots now. Everybody should work to get flu shots now. Best way to do this is through your doctor. So if you've got a preventive medicine visit or give a call, that's always our sort of first recommendation, because we can make sure your other health things are in order. Pharmacies are also now making it available. The health department has availability. You can go to chicagoflushots.org to see specifically where you can get flu vaccine. Anything you want to add about?
Well, about seniors,
yeah.
There's a high-dose flu vaccine
right.
for seniors, and I strongly encourage you seniors to get the high-dose vaccine. The immune response to the vaccine does wane over time in seniors particularly, but that's why they made a high-dose vaccine. It lasts throughout the whole season. So I can speak from personal experience. The low-dose vaccine didn't do it for me, and I got the flu at the end of the season, and that's why I switched to the high-dose, and
Yeah, and that's why one of the best reasons, your doctor or your pharmacist, they'll look at your age and sort of, sometimes people will say to me, I got told to come back, for when that's available, and usually that has to do with having the high dose vaccine available because it is more protective, especially for people who are older. But we are starting to see this come in. So now is a good time, get your shot, get it done, and that is true for kids and adults. Also, a good follow-up question here from Adrian Martinez. I haven't had a flu shot for about 10 years. Should I still get one? Yes, absolutely you should. The flu shot is designed to help protect you against the flu that is circulating in the world right now. So even if you haven't gotten one for 10 years, getting one right now, and I think it's especially true if you are, if you yourself are in a risky group or you're helping care for, or people have been thinking a lot about who's at the most risk from COVID. We really don't want people co-infected, meaning having flu and COVID together. We don't have a COVID vaccine yet, but we have a flu vaccine. So one of the best things.
So
you want to add to that?
And early in the COVID pandemic, we saw people who had both flu and COVID-19 simultaneously, and they didn't do well, I have to say. So it's really important that you protect yourself from the flu while we have that vaccine. The last flu season was overshadowed by COVID-19, but it was actually one of the worst flu seasons in modern history, and there were, I think, over 30,000 deaths in the United States from the flu. So it's something that we do have, and you need to take advantage of it. A very common myth about flu vaccines is that people think they're going to get the flu from the vaccine. That simply can't happen. Same as it's true of the COVID vaccine. You can't get COVID from the vaccine because they're not viable viruses. They're not even complete viruses. So it's so important you get the flu vaccine. Sometimes people will get some symptoms from the flu shot, like a fever or body aches, for 12 to 24 hours, and they think they're getting the flu. Trust me, that's not the flu. That's just a reaction to the vaccine that's appropriate because your body's making an immune response. The flu is quite different. It's more like getting hit by a truck, not 12 to 24 hours of fever. So.
Yeah, and the other thing is it can take a little bit of time after you get the flu vaccine to build up that immunity. So sometimes people, especially when we're in the height of flu season, which usually comes more kind of in the December to February time frame, depending on the year, when there's just a lot of flu circulating. Occasionally people will get a flu shot and then right away they think that they've gotten the flu, and they've actually perhaps been infected earlier, or the shot hasn't taken hold yet. So we don't want people to wait until January or February to get this. We want to start building that protection now.
Absolutely.
Great. Okay, Nora Naughton on Facebook has a question. I think she's interested in this strain idea, maybe like we were talking about influenza strains, and an opportunity to talk about how that's a little different from COVID. So she's asking, if the vaccines that are being developed use a Chinese strain of COVID-19 based on the Chinese genome, will these vaccines protect against the Italian strain of COVID-19 that hit New York so hard?
Yeah, well, that's a very good question. Actually, the vaccine products being used on all the vaccines that are currently about to be tested or being tested are based on the outside protein of the viral shell, which is the spike protein. There is one amino acid modification in the European strain from the Chinese, but the product that's being used now is actually modified further to stabilize that protein and make it extremely immunogenic. So yeah, it has great cross immunity, and it generates an immune response which is about 10-fold higher than a natural infection. And not only that, but it really generates the right kind of antibodies, which are what we call neutralizing antibodies. Antibodies that bind to the virus's spike protein on a natural virus and keep it from getting in your cells. So neutralizing antibodies. And so we anticipate that the vaccines will be very effective based on our early work.
Okay, perfect. And maybe talk just a little bit more about that, because there's some more questions in here about sort of how is it different if I get the vaccine versus if I just naturally get COVID in terms of protection or what we know?
Well, so when you get infected, you do generate an antibody response. We have been using convalescent plasma to use people's antibody response in treatment, although we have no evidence that it actually works. At the University of Illinois Chicago, we did a small trial which ended early because there were so many other studies going on with convalescent plasma, but ours was actually a well-controlled trial that compared it to regular plasma and actually didn't do anything. I don't know that we're going to see much of an effect. It may be, if there is an effect of convalescent plasma, it's going to be weak. And that's partly because the antibodies responses that people make to an infection are weaker responses. They vary depending on the severity of the disease and other underlying illnesses, age of the participant, or the patient rather, who got the infection. And it's also a gamish of antibodies. You know, your body makes antibodies to every part of the virus. Some of them help and some of them hinder your immune response. And so just measuring total antibodies doesn't give you the whole story. What we do know about the vaccine is it makes an antibody response, which the levels of which are about 10 times higher than the natural antibody response, and they're the right antibodies. They're specifically neutralizing antibodies. They're not a mixture of different types of antibodies. They're really just one viral protein that we're targeting, and like I said, it's modified in such a way that the antibodies that are made to it are really effective neutralizing antibodies.
Okay, great. Still getting more questions about the flu shot. So Linda Flanagan, what if you get a flu shot and also have asymptomatic COVID-19 and don't know it? So just as a reminder, the flu shot helps protect you against the influenza virus. We don't have a vaccine yet for the COVID-19 virus. So if you got a flu shot and you had asymptomatic COVID-19, I would not expect there to be any cross-reactivity there. The flu shot would help protect you against the flu in the future. The asymptomatic COVID, I would not expect in any way to, be modified by getting that flu shot.
Well, basically we have no information about what would happen there.
Well, that's also true, yeah.
But does the COVID-19 infection somehow modify your response to the flu vaccine? It's possible, but there's no interaction. They're different viruses, as you pointed out.
Yeah, okay, good. So we are coming actually up on the end. This has gone very quickly today. Lots of good vaccine questions. I think maybe we will, just to sort of wrap stuff up a little bit, anything you feel like you didn't have a chance to say or things that you want to remind people to do? We usually end kind of on a good news or things to do note.
Yeah, well, I mean, the good news is that we're doing these vaccine trials. It's amazing, actually, that we so quickly now have vaccine candidates that we can test against this virus. And when really, I mean, it's only been around for a few months, and here we are already testing in phase 3 trials vaccines that actually look really promising, and I have a high expectation that they'll be effective. At least some of them will, and possibly all of them. In addition, we have all these monoclonal antibody strategies. So we're at a point in medical science where we have these platforms for rapid development of vaccines, and it's really an incredible testament to our ability, and a lot of this work was done at the NIH. And licensed out to private companies. We have a great capability at the NIH for development of vaccine products. I want to clear up 2 common myths about vaccines that I often speak to. One is that you could possibly get the infection from the vaccine. As I pointed out, the vaccine is only the outer protein of the virus. It doesn't contain a complete virus. There's absolutely no way you could get the infection from the vaccine. The other common myth about clinical research with the vaccines is that we give people the disease to see if they're going to get it or not. We don't do that. As I pointed out earlier, we enroll people who are at risk for getting it, but we have to enroll 30,000 people in the hopes that we'll catch maybe 100, 200 cases in that subgroup, because we're not giving people the disease. If we did, we just line people up and give them the disease, 10 here, 10 for placebo and 10 for the vaccine, and we'd have the answer. But we don't do research that way. It's you can clearly I want to make the point that you're not going to get the disease by participating in the study. You get the disease by living in the world.
Okay, great, very good. And we'll make sure to, I think we've already put in the chat box, but we'll put in, again, sort of the information if you yourself are potentially interested in maybe participating in a trial. So again, if you missed the introduction, this is Dr. Richard Novak from the University of Illinois at Chicago, leading on the phase 3 trial that is furthest along at this point here in Chicago and actively enrolling folks. So really thank you so much for joining and for the work that you've done over all these years, and then building on that expertise really with COVID. I appreciate you bringing that expertise to this group.
Thank you so much for having me.
Yeah, I will just end with a couple of other sort of good news pieces. So number one, we are looking ahead to colder weather here in Chicago and doing a lot of planning around that. And in particular, thinking about ways to help encourage safer outdoor dining for customers and food service staff during colder months. And so there is actually an idea platform at https://openido.com. You submit your idea that you have for safer outdoor dining in cold weather. You submit it by September 7, and there's going to be a $5,000 prize for somebody who's got a good idea for that we might be able to use here in Chicago. So do some thinking, and if you've got a good idea, check out the website there. I also just wanted to highlight that this week we are talking a lot about the 2021 budgets here in Chicago. You may have heard the mayor's announcements yesterday about that big gap. And there are town hall series going on every evening on Facebook Live. So just like here, from 6 to 7 p.m. And you can put in questions just like you do here about the city's finances and the different ways in which we're spending. I will be on tomorrow evening with some of the other sort of health and human service departments. Public safety is on tonight, for example. The infrastructure departments are on Thursday. So if you want to understand more about how the city of Chicago spends funds, budgets, what we're thinking about in the time of COVID, it's a good way to learn about that without needing to leave your home. So you can go to chicago.gov/2021 budget. If you've got a question, you can put that in right there already, and otherwise feel free to tune in. And I think with that, anybody who is interested in hearing even more about COVID, we do have a brief press conference happening at 1 p.m., so just shortly. And we will not be in on Thursday. We are actually doing a lot of Latinx outreach strategy work, and there's some things related to that that are happening during this time frame on Thursday, so we won't be here. But next Tuesday, which marks the first week of school back for Chicago Public Schools in a virtual learning environment for that first quarter, we are hoping to have Dr. Ken Fox, who is the Chief Health Officer for Chicago Public Schools, on to talk again about schools and COVID and CPS and some of what we're thinking as we move ahead. So we will see you back in this longer format next Tuesday. In the meantime, keep giving us questions. We keep answering questions sort of on one-off, these shorter recorded. Really appreciate everybody tuning in, and lots of really thoughtful, good questions today. So we will see you back in person next Tuesday. In the meantime, please be well and take care. That is all for today. Thanks a lot.